Renal stone. So it is a very important topic. So we shall discuss our renal stones into three main categories, which are your types of renal stone, the etiology of renal stones, and your management of renal stones, where we shall be discussing a few important points in detail regarding your various endoscopic managements of your renal stone. So first, your types of renal stone. We have your calcium oxalate, calcium stone. So please remember that this is your most common stone. Now, calcium oxalate, they may occur as monohydrate or your dihydrate. Now, monohydrate, they are dumbbell shaped, whereas your dihydrate are your tetrahedral shape. Now, the most common metabolic abnormality which are associated with your renal stone is your hypercalciuria, and your most common disease associated with hypercalcemia and your stone disease is your primary hyperparathyroidism. So, these are your important one-liners which you should not miss before going for your any exam. Your most common stone is your calcium stone, the most common metabolic abnormality is your hypercalciuria, and your most common disease associated with your hypercalcemia and stone disease is your primary hyperparathyroidism. Then we have your calcium phosphide, which are your brustite or your brush brittle, usually distal, occurring in your distal renal tubular acidosis, and they are your needle shape. Now, apatite stones are usually present in cases of infection. So, your calcium phosphate stone, your brustite or your brush subtype is seen in your distal renal tubular acidosis, whereas your apatite form is seen in cases of infection. Then you have your uric acid stones. Now, these are your amorphous stone, low urine volume and acidic, which is pH less than 5.5. Now, usually associated with your diabetes mellitus, and hyperuricosuriasia is seen in your gout and your myeloproliferative disorder after your cytotoxic treatment. So, you might be getting a clinical question where a patient has received a chemotherapy for a cytotoxic a cytotoxic drug for a myeloproliferative disorder, and the patient has formed a renal stone. So, what would be your type of your renal stone, which would be a uric acid stone, or you can also have your clinical scenario where they frame it with the condition of gout. So, uric acid stones in hyperuricosuriasia, which is your gout and myeloproliferative disorders after cytotoxic therapy. Then you have your cystine stones, which are your hexagonal in shape, right? Now, they are associated with your genetic abnormalities. Now, it is due to the defect in your dibasic amino acid transporters, which includes your CoLA, right, which is cysteine, ornithine, lysine and arginine. Now, these are very hard. Why are they very hard? Because of your disulfide bond. And why do we need to remember this? Because they will not easily fragment with your shock wave lithotripsy. So, when we reading the management, please remember, if you diagnose the patient and think the patient to be having a cystine stone, an ESWL shall not work on it. Then you have your infection stones, which are your usually triple phosphate, magnesium ammonium phosphate stone, have a coffee lid shape, somewhat like this, a coffee lid shaped appearance. Then they are because of your urea producing organisms releasing ammonia, which makes the urine alkaline. The most common organisms associated include your Klebsiella and your Proteus mirabilis. Then you have your xanthine stone, which is your xanthine oxidase deficiency because of your increased allopurinol, then your drug induced because of your indinavir. Now, so these stones need to be remembered, right? So, infection stones over here, we have your steroid stones also. Please do remember, which are your ammonium phosphate stones because of your urea producing organism. So, this particular types of stones need to be remembered. Now, coming down to the next part is the etiology of your renal stone, right? It could be because of hypercalciuric, that is increase in the calcium. How can it be? Why can it be caused your high calcium levels? Because of your increased reabsorption of your gastrointestinal tract. Then in case of your renal, there could be increased calcium excretion in the kidneys, for example in your renal tubular acidosis, Barton syndrome and your Dent syndrome. Then it could be a hypercalcemia, which could be attributed due to prolonged immobilization, milk alkali syndrome and your hyperparathyroidism. Then hyperoxaluria, because of your bowel resection there would be fat malabsorption and increased oxalates in the gut, leading to an increased load at kidney. Then a primary hyperoxaluria is usually autosomal recessive, and type 1 is associated with your alanine glyoxylate deficiency, and type 2 is associated with your diglyceride dehydrogenase deficiency. Then obviously due to the increased intake of your oxalate containing food, that is your dietary hyperoxaluria. Now the non-modifiable risk factors that are associated with your renal stone disease include your age. Men, it is much more common in 4 to 6 decade, whereas in women has a bimodal peak, much more common in men compared to your female, and wide group are more at risk, and 2 to 5 times much more common with the history of family history of renal calculus. Now the various modifiable factors include your environmental factors and your drugs. Now how would be the presentation of your this calculus? So if it is a renal calculus, it could be an asymptomatic causing your dull aching pain, or it may present with your hematuria and a non-functioning kidney. Whereas on the other hand, your ureteric calculi would be causing an acute intermittent loin to groin pain associated with your nausea. There may be dysuria, hematuria, fever and sepsis. So this would be your clinical presentation of a patient coming to you with a kidney or a ureteric calculus. Now investigation, the investigation of choice is your NC-CT scan. There is no doubt or confusion regarding this, and apart from that you would obviously have to do some metabolic evaluation to rule out your hypercalcemia disorders. Right. Now the non-surgical management includes your watchful waiting. So this watchful waiting is contemplated in those cases which have intact renal function, less than 5 mm stone size, non-obstructive kidney disease and your lower pore renal calculi. Now the medical expulsive therapy is by your tamsulosin, which is an alpha-1 adrenergic adrenoreceptor blocker, which causes your smooth muscle relaxation of your distal ureter. Now the stones larger than 5 mm, it will help in assisting the passage of the fragments following your shockwave lithotripsy. So coming down to this ESWL, we had already discussed one important point with respect to ESWL, which was yes, cystine heart stones resistant to your ESWL. So it is usually done on an outpatient basis. The stone is usually localized using a fluoroscopy or an ultrasound, or we can use a combination of both. Now then what happens is that acoustic pulse waves are generated and focused on the stone. Now the stone fragmentation occurs as a result of the mechanical stress which is caused by the energy transmitted by the incident shock wave and indirectly by the collapse of the bubble. So the efficacy of your shockwave lithotripsy reduces with an increasing number of stones and volume of stone burden. So if you have a large number of stones there, your efficacy of your shockwave lithotripsy will reduce. Then we have this Steinstrasse, which is a German word meaning your street of stone. So it is your row of closely gathered stones fragments that lie in the distal end of ureter. So you can see over here, this is demonstrating your Steinstrasse. Now when does this occur? This occurs when your stone burden is high and your stones are hard. The stones are usually asymptomatic and pass your spontaneously, but they may be requiring surgical intervention when they cause your obstruction. So your clinical insignificant residual fragment, as your residual stone fragments of 4 mm in size or less after treatment are expected to pass spontaneously. However, around 20 to 40% of your fragments may not clear and form a nidus for your stone regrowth. So your end shock wave lithotripsy, specifically when you have your large load, may form Steinstrasse which usually pass, but they itself can be a source of infection. Right. Now your other surgical management would include mainly your endourological management, but when would you do it? When you have your failure of medical management, impaired renal function, a chronic infection, if the patient does not want to go for a medical treatment and does not want to stay on this large follow-up, and high risk occupation or geographical location where you would not treat the patients medically but rather go for an immediate surgical intervention. So you have your various endourological procedures. So first we have your ureteroenteroscopy. So what is your ureteroenteroscope? So these are your long thin scope that are used to remove your ureteric and renal stones. They have working channels that allow for the introduction of your energy sources, graspers and baskets. Now current models usually are your semi-rigid or your flexible scope. Now semi-rigid is usually used with the pneumatic lithotripsy and a laser energy device. Now the various complications would include your perforation, avulsion, retropulsion, right, and the ureteric avulsion can be avoided by use of baskets under vision. Now they can also be used in patients with your bleeding disorders with the moderate increase in your complication. So these are your few important points that you guys need to remember regarding your ureteroenteroscopy. Then we have your retrograde intrarenal surgery. So when do we do this retrograde intrarenal surgery? Please remember the indication when you have renal stones less than 2 centimeter, lower pole calculi, obesity, musculoskeletal deformities, and in your bleeding diathesis. Then you have your percutaneous nephrolithotomy. So this involves the removal of stone by creating a track between the skin and your pelvic calyceal system. This is done in your prone position. Fluoroscopy or ultrasound can be used for its localization. Now, which is the most common site for your entry? Your posterolateral calyx is used as the most common size for the entry. Now, ultrasound in conjunction with your pneumatic and laser lithotripsy is your most common energy source which that is used. Now the complications would include your bleeding, infection, pleural violation in case if you end up doing a supracostal puncture. Now severe bleeding may require your selective angioembolization. Now when would you do a percutaneous nephrolithotomy? When you have your renal stones more than 2 centimeter, lower pole renal stones that are unfavorable for your shockwave lithotripsy, specifically like your 16 stones which are your heart stones and are resistant to your shockwave lithotripsy. Then your failed shockwave lithotripsy or RIRs and a staghorn calculi. Then you have your contraindications to your percutaneous nephrolithotomy, which includes your pregnancy, untreated UTI, bleeding diathesis, and your current anticoagulation. Then you have your miniature percutaneous nephrolithotomy, which includes your use of smaller SS tract. Now the standard SS tract is more than 28 FR, which is compared with your miniature version using your less than 22 FR tracts. Now miniaturized PCNL is most useful in patients with a small stone burden and in children. The lateral and supine PCL are associated with your fewer anesthetic complication. So this were in just regarding your endourological management, where you need to remember your indications and your contraindications of your PCNL and when would you would use that RIRS and a PCNL. Now the non-endourological surgical management, these are rarely used these days, which include your pyelolithotomy and anatrophic nephrolithotomy. Usually they are managed with your endourological management. Now in case of pregnancy, your most common stone is your calcium phosphate. The primary mode of investigation will be your in the ultrasonography. It is an absolute contraindication to your shock wave lithotripsy. Now URS for your distal ureteric stricture and PCN can be used for your intermediate procedures to relieve in pregnancy, later followed by a definitive management. Now in children, you have again being much more common in male. Now the most common stones in children is again your calcium oxalate, and genetic disorder is associated in 17% of children with your stones. Thank you.